Good morning, everyone, and welcome to the Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. Before we get started today, I have a few housekeeping items. So number one, reminding everybody we are broadcasting live via our worldwide audience, via Venmo and YouTube. The recording is always available for viewing. And please like, comment, and subscribe, and share our YouTube channel. If you'd like to submit a question during today's Grand Rounds, please text DeBakey to 37607. Again, that's DeBakey to 37607. I do also want to remind you some of our upcoming training activities. We have the Robotics Surgery Summit on March the 11th. We also have the Re-Evolution Summit on April the 10th. And then cardiology for the non-cardiologist on May the 17th. So it is my pleasure to welcome Dr. Barry Borlaug to give us our Grand Rounds today. Dr. Borlaug is a professor of medicine and chair for research in the Division of Circulatory Failure of the Department of Cardiovascular Medicine at the Mayo Clinic in Rochester, Minnesota. After graduating from medical school at the University of Wisconsin, Dr. Borlaug trained in internal medicine at the Brigham and Women's Hospital in Boston and completed his cardiology fellowship at Johns Hopkins Hospital in Baltimore. Dr. Borlaug's research interest focuses on the pathophysiology, diagnosis, and treatment of heart failure, particularly heart failure with preserved ejection fraction, with an emphasis on hemodynamics. We're excited to hear the presentation today entitled New Insights into Obesity-Related HFpEF. Dr. Borlaug.
Thank you very much for the kind invitation and great to be with you today. Let me share my screen. Okay. Can you see this?
Yes, sir.
Okay, perfect. Okay, I tweaked the title a little bit, but it's the same talk. We're going to talk about the mechanisms by which these cardiometabolic drugs work in obesity-related HFpEF and new updates that we've learned. These are my disclosures. So here's sort of our cardiometabolic state of the union, at least 4 years ago. So these heat maps show the prevalence of overweight and obesity in the US. And the darker red colors are 80%. The lighter blue colors are closer to 50, 65%. It's really, we're dealing with a very, very serious situation here. And it's really staggering, this epidemic. Especially when you consider that back in just 1990, not that long ago, the prevalence of obesity in adults in the US was only about 20%. And it has more than doubled since just 1990. It's currently projected that by 2030, 1 in 2 adults in the US is going to be living with obesity. And by 2050, 2 out of 3 people in the US, adults in the US, are going to have a body mass index of 30 or higher. So this is really an unprecedented epidemic. And we know that obesity is a risk factor for most cardiovascular diseases, dyslipidemia, atherosclerotic disease, etc. And that's shown up here, but it's really the strongest risk factor for heart failure. And that's shown on the bottom panel here. So you can see that the risk increases as your BMI goes up, but the steepness of the slope is really greatest for heart failure. And we've known this for years since Framingham, but more recently we sort of teased out whether it's heart failure with reduced ejection fraction or what we used to call systolic heart failure or heart failure with preserved ejection fraction, HFpEF, what we used to call diastolic heart failure. And it's really, obesity is really most strongly tied to HFpEF. That's the sort of cardiometabolic end organ damage of obesity. And obesity is a risk factor in both men and women, but it's an even greater risk in women for a number of reasons. So this begs the question, why? Why do we see this? And there are many reasons. One is shown here. So this is old study, 1977 circulation. Plotted on the x-axis is body weight, and on the y-axis is directly measured blood volume in women on the left and men on the right. And you can see as your body weight goes up, your circulating blood volume increases in a monotonic fashion with a very tight relationship, especially in women. So you get more volume overloaded by virtue of acquiring obesity. It's not just excess fat in the subcutaneous depots. There are increases in visceral fat, and we'll talk more about that. One of these areas is fat around the heart, epicardial and pericardial fat. Here's a very dramatic example of that from a patient with HFpEF who was hospitalized and eventually passed away in the hospital. The total heart weight, over half of it was related to fat rather than muscle. And the combination of left ventricular hypertrophy, right ventricular enlargement, atrial dilatation, and this epicardial fat increases the total volume of the heart. And when the total heart volume increases, the pericardium has to dilate too. If the pericardium doesn't dilate as much as the heart volume increases, you get an increase in ventricular interdependence and pericardial restraint on the heart, similar to what you see in people with constrictive pericarditis. And you can quantify that by looking at the shape and configuration of the septum, and you get this D-shaped left ventricle, higher eccentricity index, and we see that in these people with obesity-related HFpEF. Now, another component that's related to this is that we see much lower levels of plasma natriuretic peptides. Remember that BNP is released, and NT-proBNP, in response to stretch. It's really stretch of the ventricle that leads to a release. So in these patients, the ventricle is not able to stretch out as much. So there's less BNP release, and patients with HFpEF, particularly obesity-related HFpEF, frequently have normal levels of NT-proBNP. And you can see here, those with obesity have a higher wedge pressure for any level of NT-proBNP. And it's not just this marker of congestion, it's also echo Doppler measures of congestion, such as the E to E prime ratio. For any EE prime ratio, filling pressures are much higher in people with obesity-related HFpEF than non-obese. So this contributes to under-recognition of HFpEF in those with obesity. They also show more RV remodeling, as shown here in patients with HFpEF. Increasing body mass is associated with more RV dilatation. There's a positive relationship between the hemodynamic abnormalities that we see and the amount of body mass present. And again, we think that this is related in large part to the volume overload associated with obesity. So as your plasma volume goes up, there's a greater increase in left atrial pressures in those with obese HFpEF, but no such relation in those with non-obese HFpEF. But it's not just volume, it's also inflammation. And we know that inflammation is very common in HFpEF. It's seen in over half of patients. But patients with obesity-related HFpEF have more inflammation, particularly as the severity of obesity goes up. And you can see here the median CRP levels increasing with higher BMI. It's not just total adiposity, it's this visceral fat. It's patients that have more of this upper body trunk and android fat in this depot, and that's particularly associated with release of inflammatory adipocytokines such as IL-6. And in this study, we took a large number of patients with HFpEF who had also undergone DEXA scans, so we could really look carefully at the distribution of body fat. And you can see compared to the lowest tertile of IL-6, those in the highest tertile had the largest fat mass index, which is plotted on the y-axis here, and the largest increases in android and trunk fat. These visceral adipocytes, they release IL-6, and remember, IL-6 acts on the liver to cause synthesis of CRP and other acute phase reactants. So this is upstream of this. And when we look at patients with HFpEF and higher IL-6 levels, they have poorer exercise capacity, whether it's peak VO2 or 6-minute walk distance. They have more severe congestion, but they also have more severe symptoms of heart failure. So these bar graphs here, this is taking patients with HFpEF and walking them on a treadmill at 2 miles per hour, 2% grade, and then asking them, how short of breath are you? How fatigued are you? And you can see those with the highest IL-6 levels in red, they report much higher levels of breathlessness, and they're much more fatigued than those with lower levels, even though they're doing the same amount of work. And this is also reflected in their chronic symptoms. So those with more inflammation have lower KCCQ scores. This is a quality of life metric that is kind of risen to the top of the heap in HFpEF in terms of ways to quantify symptom severity in the chronic setting. There are also abnormalities in peripheral oxygen uptake. Those patients with higher CRP, they're less able to increase arteriovenous oxygen content difference, potentially due to problems in skeletal muscle and the microvascular, so they can't pull the oxygen out of the erythrocytes as well, and this also contributes to their exercise intolerance. And there's also evidence that these patients with higher IL-6, it may be released in the lungs. So this is a study that's under review right now, where we measured IL-6 levels in the pulmonary artery and then wedged the catheter and then measured the IL-6 levels in the capillaries. And there's a positive gradient in those patients with a higher pulmonary vascular resistance. So this is also associated with more severe pulmonary vascular disease as well. I've mentioned visceral fat, and visceral fat is very important in HFpEF, particularly in women. This is a study where we took men and women with HFpEF and compared them to age and BMI matched control women and men. And as you can see here in this example, and this was true overall, as compared to women who with a similar degree of obesity, those women with HFpEF had a greater distribution of fat in this abdominal visceral area, this fat stored around internal organs. This was not present in men. And here we are regressing exercise wedge pressure, the hemodynamic indicator of heart failure severity versus visceral fat area. There's no significant relationship in men, but in women, even though they have less visceral fat than men, any increase in abdominal visceral fat was correlated with a greater increase in exercise wedge pressure. So this importantly contributes as well. So the question is not, why does obesity lead to HFpEF? The question is, why don't more people with obesity have HFpEF? And the answer is they probably do, but they continue to get blown off in the clinics and not evaluated. And they have, normal NT-proBNPs, if people even check that. So they just sort of ignore the diagnosis. So we all need to do a better job of finding these patients. Okay. So what do we know about treatment of obesity-related HFpEF? We know from this is a meta-analysis. This is the only meta-analysis I've ever published. This is a hemodynamic meta-analysis. This is from old studies in the 60s, 70s, and early 80s, where they actually did right heart cath before and after a variety of weight loss interventions, mostly bariatric surgery. It wasn't in patients with heart failure. It's just people with obesity in the absence of heart failure. And it's just observational data, of course, it's not controlled. But we observed very substantial proportional reductions in right and left heart filling pressures and about a 25% reduction in wedge pressure. So you would certainly expect that this would be very helpful for people with HFpEF. And here are data looking at long-term changes in cardiac function after bariatric surgery. This is a median of 4 years of follow-up. And you can see there's actually a little bit, a statistically significant decrease in EF, not clinically meaningful. It's about a 3-point drop. But LV mechanics, or LV global longitudinal strain, improves. And right ventricular strain also substantially improves. So you would also expect that this would be very helpful for people with HFpEF. But these are observational data, and they're from patients without heart failure. So what do we know about patients with heart failure? Well, we now have an abundance just over the last year and a half that has really expanded the evidence base. So this is the first trial. This is the STEP HFpEF trial. I'm sure many are familiar. So this was a trial of semaglutide GLP-1 receptor agonist versus placebo in patients with obesity-related HFpEF. The primary endpoint, dual primary endpoints were KCCQ clinical summary score and body weight, changed from baseline to 52 weeks. And this at the time was an unprecedented effect. A marked 8-point improvement highly significant with semaglutide versus placebo in quality of life score. And this was associated with a 10.7% reduction versus placebo in body weight. So prior studies with other therapies that, we had used in the past, like spironolactone and things like that, lead to like a 1 to 2 point improvement. This is an 8-point improvement, really massive effect on symptom severity. But it wasn't just symptom severity. There were also significant, nearly 20-meter improvements in 6-minute walk distance and a marked reduction in systemic inflammation, which I just showed you a few slides ago, is also very important, about a 39% reduction with semaglutide as compared to placebo. STEP-HFpEF was then followed up by a sister trial. STEP-HFpEF was in non-diabetic patients. There was another one called STEP-HFpEF DM, and same results. Again, 7-point improvement in KCCQ, again, an improvement in 6-minute walk and a decrease in CRP. And then we did a pre-specified combined meta-analysis from both of the trials, which obviously confirmed the same findings, but also showed in exploratory analyses a reduction in heart failure events. And this is what we saw. So not many events, a total of 38 events, 30 in the placebo group, 8 in the semaglutide group. That's a hazard ratio of 0.27, a 73% reduction. Not pre-specified, so we have to treat this obviously as hypothesis generating, but really kind of a surprise and a very evidence for a strong effect. We followed this up, combining the STEP-HFpEF data with two other large outcome trials, SELECT and FLOW. SELECT, as you know, was patients with cardiovascular disease and an absence of diabetes, and FLOW was a CKD trial. In both of these trials, there were a number of patients that had a diagnosis of HFpEF at baseline. So we combined all of these patients, and again, we see a 31% decrease in the risk of heart failure hospitalization or CV death, and a 41% decrease in the hazard ratio of heart failure hospitalization. And here's the forest plot that summarizes the data across all the trials. So more mounting evidence that in addition to symptoms, maybe it's also improving heart events, but again, not pre-specified in these trials. But then most recently, we published the SUMMIT trial. So SUMMIT tested a different ingredient, tirzepatide. Tirzepatide is a dual agonist. So it's an agonist of the GIP and GLP-1 receptors. It leads to slightly more weight loss as compared to semaglutide in prior head-to-head studies. And this was a trial of obesity-related HFpEF, EF 50% or greater. They had to have other evidence indicative of the diagnosis of HFpEF, but they did not need to have a high NT-proBNP. That was one of the ways into the trial, but it was not required. We also included enrichment criteria to find people who had a higher risk of events. So they had to have a low KCCQ score. They had to have a low 6-minute walk distance. And they had to have either a heart failure decompensation within the preceding year or CKD. These patients were then randomized 1-to-1 to placebo or tirzepatide, started at 2.5 milligrams per week, titrated up to a goal dose of 15 milligrams per week. And it was a double-blind treatment for up to 3 years. The median duration of follow-up was 2 years. We continued the trial until the last patient enrolled completed the 52-week follow-up visit. And unlike STEP-HFpEF, here we've set the co-primary endpoints. The main primary endpoint allotted alpha of 0.04 was cardiovascular death or worsening heart failure. So now this is the first outcome trial testing these drugs. And the additional co-primary endpoint allotted alpha of 0.01 was the change in KCCQ clinical summary score. And this is what we observed. As compared to placebo, tirzepatide led to a significant 38% reduction in the risk of heart failure, worsening heart failure or cardiovascular death. This was all driven by worsening heart failure and heart failure hospitalization. This was not dependent on oral diuretic intensification events. In fact, the effect size was even greater when we looked at worsening heart failure events, including hospitalization. And again, like the STEP studies, Again, a significant improvement in symptom severity, increase in KCCQ score as compared to placebo. You can see the placebo group also had a significant improvement, but about a 7-point improvement compared to the placebo group. And again, a marked improvement in 6-minute walk distance. So all of the metrics that we care about in these patients very significantly improved. So really impressive. And we go from having basically nothing for HFpEF to having all of these drugs. We know we have the SGLT2 inhibitors. I haven't talked about that yet, and we know that we have the MRAs now and the incretins. So lots of evidence that the majority of patients with HFpEF in the U.S. have obesity, and that we have these new drugs that target obesity. So how do they work? That's the question that we'll tackle for the rest of this presentation. Well, we know that the efficacy varies with the amount of weight that you lose. Excuse me. And these are data from the STEP-HFpEF trial, where we looked at the relationship between the weight loss achieved and the improvement in KCCQ. And you can see patients who lost more weight had a greater improvement. So going from a 5-point improvement versus placebo in those with 5% or less weight loss up to a 21.6-point improvement. And the P for trend was highly significant here. And these are data that I just presented from the SUMMIT trial with tirzepatide at the THT meeting. And you can see again here, so now each of these boxes, this is only patients who were treated with tirzepatide, looking at the change in 6-minute walk and the change in KCCQ. Those who lose more weight have much more benefit for both of these metrics. So it's definitely tied somehow or correlated with the degree of weight loss. That might lead you to believe, well, it's just weight loss, but it's not just weight loss, because the weight loss is a surrogate marker for many of the other favorable things that we see. And one of them is shown here, the decrease in inflammation. So patients who have more weight loss also have a greater reduction in CRP. Those with a 20% in STEP-HFpEF had almost over a 60% decrease in CRP levels. So this is certainly part of it. And there's other components as well that are correlated with the amount of weight loss. Here's just the summary from the two trials showing the decrease in CRP. You can see there's not as much of a change early. It tends to occur much later when the weight loss effect is maximized. But we do see that the decrease in CRP levels with treatment with tirzepatide, at least in the SUMMIT trial, were correlated with the improvements in 6-minute walk distance, and also a myocardial effect, also decreases in high sensitivity troponin T levels. So there is also evidence that the inflammation is tied to a myocardial effect. And these tended to occur a little bit later, 24 weeks. That's also when the Kaplan-Meier curves started to tease apart. So there's lots of things going on here. Okay, so do these incretins, do the GLP-1 receptor agonists, do they actually treat hemodynamics? Well, we don't really know yet. There is evidence to support this. This is from STEP-HFpEF program, looking at the changes in NT-proBNP. And you need to remember that if you look at patients without heart failure, with just obesity, if they lose weight with things like bariatric surgery or intensive lifestyle modification, BNP and NT-proBNP actually go up with weight loss in people without heart failure. So that's the normal response. So that makes these data even more compelling here. So you can see with semaglutide in blue as compared to placebo in red, there was an 18% reduction in NT-proBNP, and this occurred fairly early at 20 weeks. You can also appreciate on the bottom here that patients with HFpEF and higher baseline NT-proBNP enjoyed more improvement in the primary endpoint of KCCQ score as compared to those patients with lower baseline NT-proBNP. But there was no difference in weight loss. So maybe the patients with more severe congestion at rest or at baseline might stand to benefit more from this treatment. We observed the same thing in the SUMMIT trial. Again, a significant reduction in NT-proBNP observed very early. here just 12 weeks. We didn't check NT-proBNP that early in the STEP-HFpEF trial, but we did here. And really, no stable effect. There was not a greater effect over time. So it appears to occur quite early. So there is some evidence, indirect evidence of a decongestive effect. In STEP-HFpEF, there was also an echo Doppler sub-study, and this was presented at ESC and published in JACC simultaneously last summer. The primary endpoint was the change in left atrial volume, and in both patients treated with semaglutide and placebo, there was an increase in LA volume over a year. So that's sort of the natural history, as the LA continues to dilate in these patients. But the degree of increase was attenuated significantly in those treated with semaglutide as compared to placebo. So suggesting a decongestive effect, a lot of times we think about LA volume as sort of the hemoglobin A1C of filling pressures. So that was going down. There was a trend for a decrease in EE prime ratio, not quite significant. But we don't have invasive data yet to show whether there is decongestion. Well, what about other cardiometabolic medicines? This is a study we published a couple of years ago in 2023 called the CAMEO-DAPA trial. And this was not a 700 or a 5,000 patient study. This was a 37 patient study. Patients with HFpEF, most of them obese, 66% women. But instead of looking at KCCQ, we are taking a much more specific, focused, sensitive metric. We are doing hemodynamics. So in these patients, we performed rest and exercise hemodynamic catheterization, measured blood and plasma volume, body composition, and biomarkers at baseline. And then patients were randomized 1-to-1 to dapagliflozin or placebo, treated for 6 months, and then they came back for repeat assessment. The primary endpoints were wedge pressure at rest and exercise. And as compared to placebo in blue, there was a 20% decrease in both rest and exercise wedge pressure. So 6 millimeter mercury reduction in exercise wedge pressure, pretty substantial effect. Now, you may say that this is just due to the diuretic effects of SGLT2 inhibitors, and there was a statistically significant decrease in plasma volume. But in fact, when we looked at the correlates of the drop in wedge pressure with treatment, the strongest correlate was the decrease in body weight. In fact, the decrease in body weight was much more strongly correlated than changes in plasma volume. The plasma volume decrease was about 260 mils. The body weight decrease was 3.5 kilograms. So much more of this, it's not just water, it's not just fluid volume, it's actually body weight going down. We don't usually think about SGLT2 inhibitors as being weight loss drugs, but in people with obesity, they do lead to more substantial weight loss, and they have more benefit in patients with obesity-related HFpEF. We then went on to look at, characterize what is this weight that's lost with dapagliflozin. What is the nature of it? And as I mentioned, we measured plasma volume directly. We did DEXA scans, and we see that it is mostly fat, as shown in this donut plot. 80% of the weight that was lost with DAPA was a decrease in fat. Only 6% was a decrease in plasma volume. And when we looked at the different compartments, again, it was more of this android visceral fat that was being lost. And it was not a reduction in fat-free mass. And this was correlated with the improvements in wedge pressure again. And then we looked at with proteomics to see changes in blood markers. And there was only one protein after you correct for false discovery that significantly changed after treatment with dapagliflozin. That was peptide YY. Peptide YY is another incretin, which is released in the gut. It's a satiety hormone. So after you eat, there's an increase in peptide YY, and this signals the brain, I'm sated, I can stop eating. So the weight loss, which you think might be related to loss of glucose in the urine, maybe not so simple. There are also indirect effects on the incretin signaling axis, which may contribute to these drugs. Well, what about the vasculature? We know that patients with HFpEF, we've known this for years, they have increased arterial stiffness. And even when we treat their blood pressure well, like is done here, this is a patient with HFpEF, mild hypertension at rest, systolic pressure of 135, not too bad, but the diastolic is low. The pulse pressure is very high. High pulse pressure is an indicator of low arterial compliance, and this is very common in patients with HFpEF, including patients with obesity-related HFpEF. It doesn't seem that bad at rest, but when they exercise, this compliance reserve is exhausted, and you're trying to pump more blood into this stiff, rigid tube that doesn't have that compliance reserve, and you get this massive hypertensive response to exercise, as shown in this example, systolic up to 250 millimeters of mercury, pulse pressure of 170, really dramatic hypertensive response to exercise. And the patients that have lower arterial compliance during exercise are really the ones that have the greatest increases in left heart filling pressures. So what did dapagliflozin do to that? Well, it was interesting. So here's the baseline data at rest before exercise in our trial. Blood pressure on average a little over 150 and going up over 200 on average during exercise. Significant reduction with dapagliflozin. And this wasn't due to a decrease in systemic vascular resistance. There was no effect. This was all due to an improvement in arterial compliance, which was only evident during the stress of exercise. So these box and whisker plots show the individual patient data. You can see here there was a non-significant 6 millimeter reduction in resting blood pressure, but a 20 millimeter of mercury reduction in exercise wedge pressure. And again, this was related to an improvement in arterial compliance. And we also observed a decrease in aortic characteristic impedance. So evidence that we're really changing the mechanical properties of the arterial vasculature. We're actually de-stiffening the arterial vasculature, and this is contributing to the hemodynamic improvements we see in terms of a reduction in wedge pressure. Notably, the decrease or the improvement in arterial compliance was correlated with the change in body weight. You can see that relationship here. So you wonder, what would we see with arterial compliance with even more potent weight loss, like we're able to achieve with the incretins, with semaglutide and tirzepatide? We don't yet know, but certainly suggestive. So this indeed, the tracings I showed you earlier was a patient that participated in our trial. And again, you can see blood pressure going from 135 to 250. This is after 6 months of DAPA. Resting blood pressure really hasn't changed, but look at the exercise blood pressure. Now the systolic is only going to 180. Still high, but it's a lot better than 250. And you can also appreciate this gray here. I'm not sure how well you can see this. This is the pulmonary artery pressure. It was about 95 systolic before, and that went down a lot as well. This in green here is the right atrial pressure. That also decreased. So what is this doing to the pulmonary hypertension and the RVPA coupling? We then looked at that in an ancillary study from the CAMEO DAPA trial. This was published in JAMA Cardiology. During this study, we also did simultaneous echo and looked at measures of RVPA coupling and pulsatile load. And during exercise, we saw that as compared to placebo in black, dapagliflozin decreased pulmonary artery stiffness, improved pulmonary artery compliance, and enhanced RVPA coupling during exercise, measured by the ratio of tissue Doppler RV velocities to PA pressure. And this was all correlated with the decrease in wedge pressure. So as you decongest the left heart and lower the LA pressures, you get an improvement in pulmonary vascular loading, a reduction in RV afterload, and an improvement in RVPA coupling, something we need to keep considering. And an important attribute here, because we know, as I mentioned earlier, that these patients with obesity-related HFpEF, they have more right heart remodeling, they have more right ventricular dysfunction. Well, what about the venous circulation? We've been talking about the arteries, but most of our blood sits in veins, and you can quantify venous capacitance looking at what's called unstressed blood volume and stressed blood volume. So the unstressed blood volume can be conceptualized as the total volume of blood that fills the vascular space in a human to zero pressure. The volume in excess of that starts to increase pressure in the vasculature is called the stress blood volume. The ratio of the stress volume to the total volume is normally about 20%. When there's venoconstriction of the capacitance veins in the gut due to sympathetic stimulation, there's an increase in the stress blood volume. So here's a measure or a study where we solved for unstressed and stress blood volume in controls in gray and patients with HFpEF. This is the total blood volume. We saw that compared to controls, patients with HFpEF had a marked increase in stress blood volume at rest. And during exercise, this became even greater. So not only do these patients have more volume in general, as shown with obesity, but the distribution of that volume is different. And you can take the ratio of the stress volume to the total blood volume. If this is a higher ratio, that indicates a lower venous capacitance. And we saw it's always higher in HFpEF, these red triangles, compared to patients with non-cardiac dyspnea. But in both groups, as your BMI goes up, as your adiposity worsens, your venous capacitance also worsens. This also conspires to increase hemodynamic congestion in these patients. What did dapagliflozin do to this? Well, this is estimated stress blood volume at rest, 20-watt exercise and peak, and we saw significant reductions at each phase in stress blood volume with dapagliflozin. And again, very significant compared to placebo at each of these different stages. And again, the changes in stress blood volume, the improvements in venous capacitance were again correlated with the changes in body weight. So these drugs are really targeting the vasculature, both on the arterial side and the venous side, as well as the overall blood volume. Well, does this matter? Do these hemodynamic changes translate into improvements in symptoms? So here, this is from the same study, and now we've focused down on measures of ventilation and ventilatory control, trying to get at the nature of how the hemodynamics might translate into the symptom improvement. And instead of focusing on maximal exercise, we looked just at 20-watt exercise, because this is really kind of ADL range. This is where patients are active in everyday life. This is when they're gardening or carrying the groceries or doing something like that. Most patients with HFpEF don't exercise to peak VO2 very often. At 20 watts, as compared to placebo, just like at rest, we saw very substantial decreases in wedge pressure with dapagliflozin. This was also associated with a significant decrease in respiratory rate or breathing frequency as compared to placebo. It was also associated with a decrease in minute ventilation, a 10 for an increase in tidal volume, and a decrease in lactate. So when we exercise, when there's inadequate blood flow to oxygen delivery to mitochondria, you get anaerobic glycolysis in the cell and you get an increase in lactate. There was no effect on cardiac output. So the cardiac output wasn't going up, but the lactate was still going down. And this was correlated with the favorable changes in minute ventilation. Remember that as your lungs get congested and wet, they get stiffer, and then the muscles of respiration, the diaphragm and other accessory muscles, have to work harder, and they can generate a lot of lactate. So maybe this explains how the hemodynamic decongestion might contribute to the improvements in terms of a reduction in lactate and a decrease in ventilatory drive. Okay, what about tirzepatide? I showed you the results of the SUMMIT trial. In addition, we also looked at changes in circulatory pressure and volume. We thought that there may be a decrease in arterial afterload measured by blood pressure and a decrease in volume. So we measured systolic blood pressure at each of the study visits. You can see with placebo, there's no effect on blood pressure, but with tirzepatide, there was a marked reduction in systolic blood pressure. Not much for diastolic pressure. Therefore, it was big reduction in pulse pressure. Again, a suggestion of an improvement in arterial compliance. And you can see here, the effect is seen after just 4 weeks. This is way before you get the maximal weight loss. So there's something that's occurring very early with these drugs. What about blood and plasma volume? Same thing. highly significant decreases in both total blood volume and plasma volume as compared to placebo. Here, the changes are directly related to the reductions in body weight, which of course is a big determinant of blood volume, as I showed you earlier. So these drugs they're decongesting the circulation. They're reducing the pressure and volume overload that contributes to heart failure symptoms. Well, what about effects on the kidney? So we also measured glomerular filtration rate using cystatin C, which we use for the primary analysis because we know creatinine is released by skeletal muscle and skeletal muscle may go down. So we focus this on creatinine. At 12 weeks with tirzepatide as compared to placebo, there was a trend for a decrease in eGFR. But by 24 weeks, that had reversed. And at 1 year, as compared to placebo, there was an improvement in GFR with tirzepatide. This was also matched by a significant reduction in urine albumin creatinine ratio. So microalbuminuria, which was present in a large number of the patients, actually was improved by tirzepatide as compared to placebo. So these are also improving kidney function. Now, the decreases in blood volume with tirzepatide were correlated with the reductions in blood pressure, the reductions in albuminuria, the improvement in KCCQ score, and the improvement in 6-minute walk distance. And as I showed you earlier, the decreases in CRP were correlated with a reduction in myocardial injury troponin T levels and an improvement in exercise function or 6-minute walk distance. Well, I haven't been talking as much about the heart. What do we know about the heart? It's incomplete right now, but so far, we haven't seen much of an effect on ejection fraction, LV volumes, LV strain. We did see the decrease in LA volume in STEP HFpEF, but there was no effect on LA reservoir strain or emptying fraction. There was a CMR sub-study from tirzepatide. The primary endpoint here was left ventricular mass. We did see a reduction in LV mass and a decrease in pericardiac adipose tissue with tirzepatide as compared to placebo. So it is having cardiac effects. And again, we are seeing a reduction in troponin levels. Now, I'm not talking big-time troponin. This is high-sensitivity troponin. About 40% of the patients have detectable, levels above, 14. But even patients with this low level do have a reduction in troponin levels. And again, this is correlated with the decrease in inflammation. So there is a myocardial effect, but that doesn't explain everything. Okay, so in conclusion, hopefully I've convinced you at this point, when you see people with obesity and dyspnea, think HFpEF. Obesity has really risen to become the most important risk factor for HFpEF in the US. It's not what we used to call the little old lady's heart. It's not just this hypertensive hypertrophy in a thin woman. It's really obesity. Markers that we have traditionally relied upon, like BNP and NT-proBNP, can't use these as rule out. They're frequently normal. The pathophysiology is very complex. There is myocardial dysfunction, but there's an important role for volume overload and abnormalities in volume distribution. Inflammation related to excess visceral fat is important. Epicardial fat accumulation, extrinsic restraint on the heart, all of these things contribute. There's new evidence now, after all of these years, demonstrating an important fundamental role for weight loss as an effective treatment. We know about semaglutide and tirzepatide, but we also see these intriguing signals with SGLT2 inhibitors working through a variety of different mechanisms that are correlated with the degree of weight loss. There is more data coming soon, both with invasive hemodynamics for semaglutide, but other novel weight loss interventions. And the mechanisms are very protean, but likely involve improvement in hemodynamics, loading conditions, cardiorenal function, and others. So with that, I will stop and happy to take any questions. Again, thank you very much for the invitation.
Thanks, Barry. That was amazing. A great kind of overview and then deep dive into a lot of the pathophysiology that we're seeing now with HFpEF. So I guess a practical question. So when you have a patient that comes into your office who is obese and short of breath, and you suspect HFpEF, what are you starting medication-wise? Like, do you jump right in to some of the weight loss meds? Are you starting with, the SGLT2 and spironolactone? Kind of give us a little thing into your management of those patients.
Yeah, I think, if I've made the diagnosis of HFpEF and they have obesity, I would start them on both an SGLT2 inhibitor, either empagliflozin or dapagliflozin 10 once daily, and a GLP-1 receptor agonist. Now, the problem is paying for it, as you all know. These drugs are already approved for obesity. There's not an indication right now for HFpEF, but they're approved for obesity. But the problem is getting it paid for, and too often we're not able to do that. But in a perfect world where we could do that, I would start them both at the same time. There were patients who were treated with SGLT2 inhibitors in both SUMMIT and STEP HFpEF, and they had similar benefit as those who were not on SGLT2 inhibitor. It wasn't a large group, of course, because SGLT2 inhibitors are a newer thing. But I think I would definitely treat with both.
Okay. Now, questions that come in just, with the issues with NT-proBNP not being that helpful sometimes with a diagnosis, and with issues with the echo Doppler, how do you approach the diagnosis, and when do you move to cath?
Yeah, great question. This is where this diagnostic scoring systems, I think, can be helpful. We came up with this score called the HFpEF score, published a couple of years ago. It's easy to calculate. It's based on 4 clinical variables: the presence or absence of obesity and atrial fibrillation, age 60 or higher, and being hypertensive, treated with 2 or more, and then 2 echo Doppler measures, EE prime and RVSP. And if that score is high, it can range from 0 to 9. If it's 6, 7, 8, 9, you can pretty much take it to the bank that it's HFpEF. If it's a score of 0 or maybe 1, it's very unlikely. If they're intermediate, that's really when you need more testing. And those are the patients that we take to the cath lab and do invasive exercise testing. This really gives us a definitive answer, whether they have it or not. Now, some people have advocated for stress echo. Stress echo, when it's abnormal, is pretty good. It's very specific. The problem is its sensitivity is not adequate. It misses about 25% of patients. So I don't rely on stress echo. We're working on a paper right now where we've got specific cut points where we can definitely rule in or rule out from stress echo, but you still are left over with this large population of people with intermediate probability who need to go to the cath lab.
Okay. And Barry, if you don't mind, maybe if you can review for us what you consider a diagnostic or positive diagnostic cath lab test. So when you do your exercise stress test, what levels do you look at to say, yep, that we've confirmed HFpEF?
Yeah, we use a wedge pressure of 25 or higher during exercise, any point during exercise. So it can be just during early level exercise, and really that's probably just as good as peak exercise, to be honest. So a lot of people worry about, getting their RER up really high or getting their maximal heart rate up. But I think if you see it even during low level exercise, that's good enough. If the wedge pressure is elevated at rest, if it's 15 or higher at rest, that also would be diagnostic. And then the other thing that you can do without exercise is just getting the legs up, just a passive leg raise. And if the wedge pressure is 19 or higher, that's also sufficient evidence.
Got it. Okay. So kind of going back into kind of the basic stuff, with these inflammatory markers, do you see that we're maybe opportunities to target some of those specific, areas? And what do you see in the future in that area?
Yeah, there's a lot of interest in that. CANTOS, the CANTOS trial, canakinumab, which is not being used, for coronary disease, but they did look. There was a pre-specified ancillary study, and they looked at heart failure events, and there was signal for a heart failure event reduction, which was especially in people who achieved a low CRP, less than 2. So that's being tested in another trial called Hermes, and it's funded by Novo Nordisk, and they have a drug that's a specific anti-IL-6 called ziltivekimab. And so that's an outcome trial that's currently ongoing. It's not fully enrolled. It's a worldwide trial, and that's going to test whether reducing the inflammation will improve outcomes in HFpEF. This drug leads to really dramatic decreases in CRP, like a 90% reduction in CRP after just like 12 weeks. So more potent than we see with things like semaglutide and tirzepatide. I think, one question is if the inflammation is just due to the obesity, should we just treat the obesity first? And that's a valid question. But we're really just scratching the surface right now. We're going to know a lot more in a couple of years.
Got it. So another question that came through, maybe talking a little bit about the role of Entresto in HFpEF. And then I know you mentioned about SGLT2 and then talked about aldosterone inhibition, but maybe where you feel that aldosterone inhibition falls in your armamentarium.
Yeah, that's an important question. So Entresto, sacubitril valsartan, was tested in the Paragon trial and just missed. P-value of 0.06, about a 13% decrease in heart failure rates. So people argued that this whole concept of a P of less than 0.05, just slavishly relying on that is kind of silly, and convinced FDA that we could expand the indication for others. So that was done a couple of years ago, but the effect is pretty minor. It really wasn't a dramatic reduction in events. There is a 2B indication, which means may be considered. A lot of times we can't get it paid for in HFpEF patients. It's still very expensive. And a lot of times after you get them on these other drugs, they don't have a ton of blood pressure left. And Entresto, is a pretty good vasodilator, so it lowers blood pressure and, a little bit of an increased risk of hyperkalemia. And this is important when we're talking about MRAs. So we don't end up using ARNIs that much. I think people that have like really recalcitrant hypertension and things like that, who are already maxed out on the other drugs, who have the resources, to pay for it and get it, I think it's very reasonable to use. But I would say that the uptake is not super high. But I think it's a tool in the toolbox after you use the other evidence or the other drugs first. The MRAs, that was in that same kind of category, like a 2B indication, but then Fine Arts was published last year. So Fine Arts was finerenone, a non-steroidal MRA versus placebo, and that hit on its primary endpoint. I think about an 18% reduction in heart failure rates. So now we've got that, and then we've got the Top Cat Americas. So I think we've got more compelling evidence to use MRAs. So in the patient that you mentioned there, what I would do, like at the beginning, your first question, I would start them on an SGLT2 inhibitor and a GLP first, and then I would see them back. And if they're still symptomatic, then I would start an MRA. But because of cost, I would probably just start spironolactone. Finerenone is still very expensive. There's no evidence that finerenone should be that much better than spironolactone. So personally, considering cost and to the patient, I would probably just use spironolactone.
Yeah, I think that's really similar. I think a lot of what our practice is, just as you said. Now, unfortunately, we have a lot of cost issues with trying to get the GLP-1. So honestly, we usually, or at least in my practice, it's kind of like you said, the more SGLT2 MRAs. And then if they have blood pressure, going to ARNI if they can afford it, and then trying to finagle some way to figure out how to get the GLP-1s, or, hopefully, and in some patients who can afford it independently. Yeah.
Exactly.
Well, Barry, it's been great. I really appreciate, your time and your insight on this. I think it's such an important topic that I think gets a little glossed over sometimes, and I think the patients historically have really been underserved by the medical community. So I really appreciate you leading some of the efforts to highlight this disease and also help us to be able to implement mechanistic treatment or mechanistic reasons why our treatments may be impacting our patients. So thank you so much. The other thing I'll just say is a little bit of plug and kind of interesting on timing. The new issue of the Methodist DeBakey Cardiovascular Journal just released recently, and it's actually all focused on obesity and the heart. So I think a great segue of being able to get this primer to then be able to dive in a little bit more there as well. So thanks again, Barry. Thanks for everyone who joined us. Y'all have a wonderful day.
Thank you.